you will start realizing that the subject is very fruitful and it's not as forward as you think it is. So gastroesophageal reflux disease was first described in 1935. 47, the clinical and radiological findings were started to be elucidated. In 51, the pathogenesis and pathophysiology was explained partially. And in 1960, the surgical procedure was done. So the diagnostics have evolved over the last 4 decades, and still there isn't really 100% among those. And we'll be talking about how to diagnose the disease in a clinical sense. The gastroesophageal reflux is the physiologic passage of gastric contents into the esophagus, and that's simple. But the disease itself is associated with troublesome symptoms or complications, and that's very important. As you all know, most of us have experienced some reflux episodes, but few of us will have the disease per se. So for the pathophysiology, there is always a belief that there is a lower esophageal sphincter, which is a high pressure zone. So if you go for anatomical dissection or histological, you won't find a well-defined bulk of muscle in that area. But when you use the manometer, you will see that there is a high pressure zone that helps prevent reflux in normal individuals. So what closes the esophagus and prevent that? We have this lower zone. We have the pinch cock action by the crura of the diaphragm. We have the intra-abdominal esophagus, where the abdominal pressure will act to close it compared to the thoracic pressure. There is also talks about the angle of His, and that usually have something to do with the way that the food goes in. And when the fundus is full with food, that part of the fundus will press in the esophagus and close it. The mucosal rossetti, that also has something to do with the mechanism by which the acid is prevented from going up, and the abdominal pressure that we mentioned earlier. So what opens it, on the other hand? We have the intra-abdominal pressure, the gastric contractions and LES, and the gastric volume and the coordination of the peristalsis and the pylorus. For the intra-abdominal pressure, we all know when you cough or when you have a high intra-abdominal pressure, the reflux is high. Gastric contractions and the lower esophageal sphincter has something to do with it. If the sphincter is weak and the contractions are vigorous, you will have reflux. And the gastric volume itself also, and the coordination between the peristalsis of the stomach and the pylorus. Just imagine that the stomach is moving nicely or even vigorously, and the pylorus is not relaxing as it should be, then you will have a high intragastric pressure that will lead to the reflux. And this is what we're talking about here. This is the area where you think that there is a sphincter, high pressure zone, and this part of the esophagus, the abdominal one, and the stomach with its motility and the opening here at the pylorus. So when you are assessing any patient, you really have to ask yourself about how the dynamics are occurring in this individual patient in order for you to understand why is this patient having a reflux per se. So anatomically, if you have a hiatal hernia, you have lost your intra-abdominal esophagus, and the individual will start having free, reflux because of the absence of that part. It is actually believed with the early surgical procedures that the resumption of the intra-abdominal esophagus is one of the most important steps for that surgical procedure. Short esophagus says the same. Gastrostomy tube, when it pulls the stomach to the abdominal wall and changes the anatomy of the or the position of the stomach, you may have some dependence in the flow of the gastric contents into the esophagus instead of going to the distally to the pylorus. Esophageal atresia, because we push and pull because the esophagus is short by definition, part of the GE junction maybe will end up in the stomach. Thrombelly syndrome, when the abdominal pressure is almost zero, you won't have that action on the abdominal esophagus. Caffeine, chocolate, nitrates, calcium channel blockers, these are all blamed to relax the lower esophageal sphincter and create reflux. Neuronal disability, that usually comes sometimes with gastroparesis or so, and that usually creates the gastroesophageal reflux. And something described as the transient LAS relaxation, and that came after the development of the manometry and also the pH monitoring. Some patients may have a transient lower esophageal sphincter relaxation at certain times of the day with no real cause that can be detected, and that could create a massive gastroesophageal reflux. So what are the aggressive factors here? The acid and pepsin, and sometimes even the bile acid and trypsin are coming if there is a reflux at the pyloric area. How the mucosa is defending itself, or the esophagus? First, the mucosal defense with the prostaglandins and so. The second is the esophageal clearance, and that's very important because when the esophagus moves and do the real peristalsis, there is a clearance. So whenever there is an acid in the lower part of the esophagus, it pushes back with these waves, and that pushes the acid back to the stomach. Gravity helps. That's why sometimes we put babies in sitting positions in order to help it. And gastric emptying is very, very important. If the stomach is not really mobilizing its contents, the intragastric pressure will build up and will overcome the lower esophageal sphincter. And also there are talks about buffering by saliva for the acidity. What are the complications? Esophagitis. It's an inflammation, usually in the lower esophageal part, and that can go all the stages from a simple inflammation, a stricture period. The next one is a stricture, usually as a consequence for esophagitis. Failure to thrive, that's very important in the pediatric population. Sometimes you may not have a lot of impressive symptoms other than the failure to thrive. Respiratory complications, this is very significant and can cause to a full array of respiratory symptoms. Barrett's esophagus, when you have some mucosal changes towards neoplasia in the form of Barrett's esophagus, where the squamous will change to metaplasia and have some columnar in there. The physiological distress, the psychological distress, and that's seen usually in adults more than kids, but it can be also described there. So how do they present in pediatric population? Regurgitation and vomiting. Failure to thrive, as I mentioned before, because they don't want to feed, because every time they feed, they get the esophagitis burn, and they try to avoid it by stopping feeding. Irritability, hematemesis if you reach the stage of severe esophagitis, hemorrhagic one. Food rejection, as I mentioned. Heartburn in older kids, and dysphagia when they develop strictures. The respiratory one starts from night cough, wheezing, apnea in small ones, aspiration pneumonia, that's the most common one. Some of these babies are referred to our care thinking that there is an H-type fistula, and when you do the test and you do your scopes, you find only that this patient has severe reflux that need to be managed. Sandifer syndrome, this is peculiar to patients with developmental delay and CP patients where they have abnormal myotonic chorionic moves, and usually it's in the form of arching of the back, and most of the patients wrongfully they are managed by the neurologist as part of their neurological disease, but with time, as the proper studies are done, it is caused by reflux disease. So how to diagnose those patients? In my opinion, history is very, very important, whether it's from the parents or from the child himself, if he's able to give history. Many patients, when you start talking to them and take their history, that will give you an idea what is the problem. And that's very important. You really have to know what is the real problem so you can direct your management. And we will be talking about those later. The next thing is to know the events. How does it come? For instance, some children may vomit, but they vomit because of a respiratory issue rather than the other way around. So you really have to know if they have a chest problem to start with and the reflux is secondary to it, or it's the other way around. Investigations, it's almost standard. The upper GI Contrast Study. First of all, the swallowing mechanism. You want to know if this baby is swallowing normally. Some of these patients, they have incoordination of the swallowing mechanism, especially in the neurodevelopmental delay patients. And that's very important for you to understand because that will help plan the management. Some of them, the reflux is induced by a coughing or by regurgitation at that level. The motility and the anatomy of the GI also is seen. The only problem is the sensitivity. The sensitivity is 40%. What does that mean? In 100 patients who had reflux disease, if you do a contrast study on them, I'm talking about the meal now, that's going to delineate the GE junction area, only 40% will be positive. Why is that? Because the tests usually take 5 to 10 minutes in the hand of the radiologist in order to tell there is reflux or not after he fills the stomach. And that's very low. When you go for the reflux scan, that takes an hour and a half under the monitor. And that's why the sensitivity goes to 80%, especially if they do the late films in patients who develop respiratory symptoms. These films are taking about 4 hours or to 6 hours after the study, and they do a screen on them. And if they find it in the lung fields, the tracer, they will conclude that there was reflux and this is an aspiration secondary. Nonetheless, the reflux scan gives you a very good idea about the gastric motility because of the time. If you join both, you will have a sensitivity 90 to 94%. This is where these pictures are showing, and this is the nuclear scan, in 1 hour and 2 hours and 4 hours. Now, the pH monitoring, our colleagues, the pediatric gastroenterologists, are very, very enthusiastic, and that's wax and wane with time. Some of them, they say, don't waste your time, just go for the pH monitoring in kids. Any study will not give you a good, conclusive answer, but the pH monitoring will give you up to 98%. In my opinion, you don't really need it. Clinical picture, i.e. the history, plus the contrast study, with or without the nuclear scan, is more than enough to make the diagnosis. I'm talking about mostly the ones that we face here in King Faisal, and most of them are the developmental delay patients. Nonetheless, the normal ones, even I think you can conclude from the history and the contrast study, most of the information that you need to make the diagnosis. pH monitoring advantageous in a way that it quantifies the reflux with numbers. It also correlates the symptoms with the pH at the lower esophagus, and the atypical symptoms like the Sandifer syndrome can also be detected by the pH monitoring since you correlate that abnormal movement with the pH number. The upper GI endoscopy is actually a good test, but it's invasive, and most of the time when you do it, you're really doing it because you have a problem with all these tests. The pH monitoring, for instance, it's not very widely used in pediatric population because the difficulty of placing the pH monitor itself. And even if you put it and the child starts moving, that could also change the position of that monitor, the sensing area, and that could give you false results. Endoscopy is reserved for those that you think that they have severe esophagitis or Barrett's esophagus, or if you are not really sure if there is any other pathology, and that's why you do it to detect it. But nonetheless, it is considered in some centers the golden standard. And this is where it comes. Even in some new centers, they have correlation between the pH and the manometer, and that's really highly sophisticated. And these are just photos to show you, here is some esophagitis, severe esophagitis, and this is Barrett's esophagus. And this is even in the severe ones, especially with the swallowing coordination issues, where you have inflammation around the vocal cords. So what is our goal in the management usually in pediatric population? Improve their nutrition, control their symptoms, and prevent their respiratory complications. The non-operative management in those, semi-seated position for these small ones, thickened feeds, frequent small feeds. Some people, they claim that there is 70 to 80% success rates, but the evidence really is lacking in any controlled studies. Most of these babies who said to be controlled, I think they are having other factors that are affecting their improvement. Let's say if a baby is overfed, and they vomit, if you correct all these things, you probably already corrected the feeding pattern, and that helps as well. Continuous feeds sometimes is one way of doing it in tiny ones. You just put an NG and you start the pump feeds. And medically, the prokinetics, we really don't have good prokinetics these days. Motilium used to be used, but the efficiency and effectivity of it is low. And lately, there have been a lot lot of FDA issues, and it's not recommended to be used for long term. H2 blockers, that's to manage the inflammation, and the proton pump inhibitors are also used. The H2 blocker, Zantac, is the most popular now. I think it's taken off the shelves, and we only use now Losec for that purpose. So attention should be paid to increasing the evidence of inappropriate prescriptions of proton pump inhibitors in the pediatric population. This is a statement from the North American Society for Pediatric Gastroenterology. Why? In my opinion, doctors, they don't really spend time to A, diagnose their patients, and B, to follow them. Any child who comes with vomiting or all signs of reflux, they just put them on these proton pump inhibitors and they forget about it. That's very, very dangerous, because if you put those patients on Losec for long time, kids will be on it, for indefinite, and that we're talking about 50, 60 years, and that's a lot. There are some reports of development of carcinoids in the stomach because of the hypertrophy that occur after these proton pump are put on board. My advice that you start them on those, you monitor them, and you start to wean it off or manage them anatomically, even with surgically later. So what are the surgical management options for gastroesophageal reflux disease? The surgical indication is that there is a failure, if you have a failure of medical therapy or complications. Complications, we do understand. The problem is the failure of medical therapy. And this is something, difficult to predict. Like, one physician may preclude that he failed his medical therapy, but if you really go to the pattern of that management, you find that there is a problem with the weights delivered or the compliance or something like that. Nonetheless, if they have complications like failure to thrive, respiratory symptoms, these are the ones that has to be, addressed. And failure of medical therapy, it's debatable among surgeons and physicians. The preoperative assessment is very, very important. So you really have to know the basics of the patient, as I mentioned earlier. And this picture here shows you here. You really have to know what is going on with the swallowing. This is very important. If a child is having some problem with swallowing and they develop chest infections and it is blamed on reflux, then you're really missing the point. The motility of the stomach is a very important aspect as well. So you really have to make sure that the esophagus is moving well and clearing itself as part of the mechanism. You have really to assess the mechanisms that we mentioned earlier at the GE junction. You also have to know about the gastric motility. You really have to put it in your mind when you are designing the treatment. And finally is the pylorus. We all know any patient with pyloric stenosis, they keep vomiting unless you open this area. So all these has to be in mind when you are managing these patients. Why am I saying this? We are faced in the clinic by some, or some consults in general by saying, please put a gastrostomy tube for this patient because the patient is failing to thrive. If you do just a GT, but this patient has severe reflux, you're not going to help him because you're going to actually make it worse. If you do both fundoplication and gastrostomy and you don't know anything about the pylorus, you're really setting this patient to a devastating gastric bloat. If you do gastrostomy and fundo without knowing what's going on up here, you will not be able to control the respiratory complications of the disease. So you really have to know what you are dealing with and what is the anatomy of this patient and the physiology of the passage of that bowl of food. So for the surgical management, what are the procedures that's been done for reflux disease patients? As I said, gastrostomy tube. If they don't have major reflux, but they have issues with swallowing or they have some gastric issues, gastrostomy tube with careful feeding may get you through. When I was in training, to be honest with you, we haven't done a lot of fundoplications. Most of what we did were percutaneously, endoscopically done gastrostomy tubes. And 2 of them only that I can remember in 2 years that we ended up to take to the OR and do fundoplications. But those patients are very patient. They start with pumps. They give boluses if tolerated, if not or not. Most of these were developmentally delayed patients, and people claim you don't have to do fundos because the rate of recurrence is high. The gastrojejunostomy is also the same. If the stomach is not moving well, people will pass a gastrojejunostomy through a gastrostomy tube, and that will also give you the same results, which is feeding the baby without complications of reflux. Fundoplication is the most common surgical procedure practiced. Whether you do it a full wrap or partial wrap, it doesn't matter. You just have to know what you are doing. And if you do it right, I think they are mostly equal. I do mostly 360. Most of pediatric they do that. But even in the 360 degrees, there are some technical pitfalls that you really have to watch, and we'll talk about it later. As I mentioned, GT and JT also is an option. Some patients are very difficult, so you just have to put a GT to drain the stomach, believe it or not. And the J tube is to feed, which is separate through a jejunostomy tube. Some of them, they say the stomach is not bad. The patient can manage his own secretions, but you can't feed in the stomach. So you just put a jejunostomy tube. And the approach, as you all know, whether it's open or laparoscopic nowadays with the prevalence of the minimally invasive techniques, most of these procedures are done laparoscopically unless there are contraindications to that. So if you do a fundoplication, what are the complications? We're going to talk about it later, but very important to know what are the complications here, so you will take care of how to do it and also how to manage these patients afterwards. I see people are trying to ask at this stage, shall we leave the questions till the end or shall we stop?
We can leave all the questions in the end of Prof.
Okay, please write them down and we will be able to cover them, inshallah. We have enough time. So
thank you.
The complications of fundoplication reported as gastric bloating, whether it's acute or chronic. Dysphagia, of course, the bloating, if the stomach is not moving well or the pylorus is tense, the stomach itself will always be distended. Dysphagia, when your wrap is tight or the esophagus is weak, like in patients with achalasia. That's why you really have to be careful of what type of fundoplication to do with the achalasia patients, because if you do a full wrap, even if it is not tight, the esophagus is very weak, it doesn't move, and you will have dysphagia still. Recurrence of reflux, and we will talk about this. This is very sensitive because whenever you mention recurrence, the medical people will be on top of your head saying, please redo the fundoplication. Those people who worked with me, they know I'm very, very sensitive for the word redo in fundoplication. And you really have to be careful not to go for a redo unless you are 100% sure that the problem is in that GE junction. And if you really make it or resume the strength of the fundo, that the patient will be fine. You are always alluded by the story given by the family saying he was perfect for 3 years after your surgery, doctor, but now I think it just opened. Please go back and tighten it. Be careful, because most of these patients, especially the developmental delay patients, they progress in their primary disease. What does that mean? The stomach itself is not moving as before. And that's why the intragastric pressure builds up higher than the fundo itself. And that's why it overcomes it, and they start vomiting and refluxing again. Disruption, as I said, and this usually, if you do it right, it should not disrupt. Hiatal herniation, that's when the whole thing goes up, and that usually goes with the short esophagus, or in some patients where the hiatus itself is wide, not fixed during the procedure, the whole thing could go into the chest. Slipping crab, this is very important because sometimes we face some difficulties in the OR and we end up just pulling whatever we can and put the stitch. And if this crab is low on the stomach or on the esophagus, it could slip on the esophagus, on the stomach, and obstruct the stomach. Open versus laparoscopic versus endoscopic now. I'm not aware of any endoscopic ones done in small babies. When I say pediatric here, all what I think about is the 3 and 4 and 5 kg, but you could be dealing with a pediatric patient who is 16 years old and he's almost an adult. So the endoscopic option is viable. I don't have any experience with it. I never did it. In the last 2, 3, 4 years, I think it's been popularized in adult and in the adult population. I don't know about the results. They claim it is good, but be careful if you want to use it for the right patient. The laparoscopic approach now, it is the conventional one is the most common. Single port now, is for the last 10 years at least, it's there. You just have to have the right patient for it. And robotics. I have done the robotics. I don't think the robot series is adding to the patient much. I've done few, then I stopped because with conventional, we are really good at it. Within 30, 40 minutes, you are done with the procedure. While if you want to use the robot, ducking itself, even if you are in the best place, I don't know those people who use the robotics, but when we use them here, they need like 30 to 40 minutes to put the ports and fix them to the robot, then you go to the console to work. Now, what kind of ports we use? I usually use 4 ports, one infra-umbilical one. Sometimes we move it on the on the midline up towards the epigastrium if the abdomen length is high or there is a dome. because you don't want to sit in infraumbilically, you may not be able to see. And another 2 ports on the right and on the left. And what I use is the 3 millimeters. And the 4th one is at the gastrostomy port part. Most of the cases that I do, we join a GT with the fundoplication. The reason is most of the patients that we manage here at King Faisal are from the developmental delay patients who needs a gastrostomy tube for feeding. Most people use 3 or 5 in pediatric population. And I think these are the ports that use. Some people, they use a 4th one in the epigastrium or a 5th to hold the liver separate than the other 2. When they finish, they develop the gastrostomy. I usually start by delineating on the abdominal wall the costal margins, because you want to know what is the gastrostomy related to it. After you inflate the abdomen, you will lose that relationship. You may end up putting the gastrostomy in an area. When you deflate the CO2, you will find it sitting at the costal margin. And that's very, very bad, because this can start creating ulcers. So you really have to draw these anatomical, guidelines about the costal margins and the midline. And then when you go inside and inflate and you start seeing the pylorus and you decide on the place of the gastrostomy, you take the stomach up to the abdominal wall and you know where it will go on the abdominal wall, realizing that you have to put it in a safe place away from the costal margin. The dissection usually starts with, it depends on what you prefer. I usually go for the fundus to the left side, and I usually do the minimal dissection. The mini dissection started in 2005, 2007. We used to skeletonize the esophagus. So I'm going to show you the videos in a second in order to, resume the abdominal esophagus and to be able to see the retroesophageal space, do the fundus safely. But to be honest with you, since 2007, 2008, I stopped doing that. I only dissect, I mobilize the fundus, or the area that I want from the fundus. Sometimes I take some of the short gastrics, very rare though, because usually the fundus is enough to it to do the wrap without mobilizing the short gastrics. Nonetheless, sometimes the spleen is close by and stuck to the fundus, so you really have to mobilize. Then we continue till you reach the left crura. After that, you shift to the right side, you open the gastrohepatic ligament, and you see the right crura, and then you start dissecting behind the esophagus, and I'm going to show you in the video. When you create the window, of course, you assess the hiatus itself. If it is wide, then you close it with 1 or 2 interrupted stitches. I usually use 2 silk suture for my fundus. And then after that, you pass this fundus from the left to the right, and you suture to itself anteriorly with 3 interrupted stitches, incorporating the anterior wall of the esophagus and fascia or alveolar tissue around it in the upper 1 or 2. In few cases, I have to do only 2 because there are tiny babies. I've done, the smallest I did was 1.8 or 1.9 kg. And those ones, you do want to do a long fundu because that may create a dysphagia. Most of the surgeons will use 360 fundoplications. This is very important to know. If you want to do anything less, it's okay. You just have to master the procedure that you're doing. You do want to be using a lot of fundus, because if you use a lot of fundus, you may not be able to, create the pressure that you need. And that's very important. Sometimes when you even put the stitch and you start checking, you'll find that it is really, really loose. We are not after a tight one. I don't usually use bougies or sizers in order to maintain a volume. You just have to make it a little bit tight, and that's all what you need. I only maintain an 8 French NG tube in the esophagus and the stomach, just to help me identify the esophagus. Sometimes I like to identify the tube itself to give you a feel. But I never really use bougies, because some articles, they give you even age or weight and the size of the bougie that you have to put, and that entails that you have to be really making stitching around it that's going to be tight in order to make an efficient wrap. And this is an area that I want to mention here. The fundoplication does not work with the mechanical suturing. It's not that we are taking the fundus and tying over the esophagus. No, it is a dynamic one, because when you create that wrap, you really are a wheel around the esophagus. And what you are after, when the stomach is full with food and the intragastric pressure is increasing, that area also will increase, and that will press on the esophagus and prevent the reflux. It is like the sphygmomanometer that you use for blood pressure measurement, because when you put it, it's not tight, but when you start putting the air, you feel that it is painful. It means it's pressuring your arm. This is just a video to show you. These are short videos, two of them. One of them is very early, and that shows you how to how is it done with scrutinizing the esophagus. See, as you can see here, you come anteriorly and you start incising the areolar tissue and membranes around it. I think this case I've done in 2005. You see here, you're really pushing on the esophagus lower, and you're dissecting retroesophageally in order to create the window. See, the window now here is created. The hiatus is okay. Now this is the shoe shine. And this is the tying of the last stitch, probably. There is a learning curve, by the way. When you start with those, you may take at the beginning an hour and a half or so, or 2 hours even. But when you start doing more, especially with the minimal, like I finish things now in 35 minutes to 40 minutes max. This is another video, and that just shows you a few tricks. Before I started, notice that the gastrohepatic ligament here has this major big vessel. This is aberrant vessel, so you don't want to really cut it. So most of the time, I open this part from below. When I finish dissecting from below and dealing with the hiatus from below, I bring the fundus this side, then I exteriorize it through this window. Here, I'm making the window ahead. I'm sorry for the picture here, but I think you will see most of what is there. I think this was done in 2009 or 9. See now, most of the tissues anteriorly are not disturbed. The hiatus here is wide, you can see. The fundus has been mobilized on this side. See, this is the crura there. The window is created. The hiatus will be managed now. Have a look at this move. See, you go reverse with the needle without holding it hardly. You just push it a little bit till you get to when it is really through the window, you take the tip and you take the left crura. The other option is to go on the other side, take it, then pull it from the window. Here now we're taking the crura on the right side, on the right side. Just be careful of the caudate lobe when you take that. And remember, when you hold this needle inside, it is like a knife. When you leave it loose, it's safe. So don't be very adamant in holding it all the time. So this is the fundus here pulled through the upper window, as you can see, above the vessel. And this is just to fix the orientation of the needle. Again, you really have to make sure that you are not utilizing a lot of the fundus. This is taking now the anterior wall of the esophagus and tissues in order to minimize the slippage of the wrap itself. Always watch your needle. Sometimes the back of the needle is more dangerous than the sharp end, because you're paying attention to the sharp while the back is doing the damage. This is now being tied. So now, this is just about the procedure. Now we're going to start talking about GERD in special cases. Now, neonates less than 30 days and infants less than 1 year, how do they present? Most of the time, failure to thrive and respiratory. Vomiting is one way. Very rare that you will have hematemesis or other symptoms. Dysphagia could be a presenting symptoms because they get the symptom, they get it, they don't, that's not recognized, and they end up with a stricture. How to investigate them? Usually an upper GI endoscopy. History and upper GI endoscopy is more than what we need. From there, you go for the management, the medical one, and you go for the surgery. When to operate, respiratory complications, as I mentioned before, failure to thrive, if there is a stricture, and patients with tracheoesophageal fistula and congenital diaphragmatic hernia are special cases. We're going to talk about them, I think, more later. But those patients, there is a claim that 50%, especially for the esophageal atresia, 50% of them may end up with an anti-reflux surgical procedure. In neonates and infants, because of the size, there is always a laparoscopic challenge, especially for beginners. So it is stated in the literature that you will be proficient after 28 procedures, 20 to 60. The time will go down from 178 to 90, then to 30 minutes if you're really good at it. The conversion rate, again, maybe 1/4 of those when you begin, maybe now, can be converted. But if you really become good at it, you should be within 2 to 3%. Currently, I can't really remember cases that we have to convert unless there are severe adhesions from previous operation, or you have a patient who cannot tolerate the pneumoperitoneum during the case because of lung issues. The complication rates, again, from 15%, you can go to 4% when you perfect the procedure. What are the outcomes here? A success rate technically anywhere from 70 to 100%. Redo fundus, this is mentioned, 7 to 26%. In my opinion, if you really do it right at the beginning, the rate of redo should be 0. What are the associated anomalies that can act negatively on fundoplication in this age? As I said, if you are dealing with a tracheoesophageal fistula and esophageal atresia patients, why? Because when you do them, they are really difficult because the esophagus is short. In my experience, when you do it after 6 months to 1 year, usually the esophagus is fine. You can mobilize it because it got elongated with time. But if you try to do it quicker, especially in the long gap, and you did a primary anastomosis, sometimes it's very difficult, and you have really to think about Colles procedure here, where you lengthen the esophagus and you wrap the fundus around the lower part. This is very important, and that's why you have to know your patient before you go. And the contrast study will give you an idea where's the G junction sitting when you go for these cases. The CNS disease, the failure rate is 20%, but this is not because mostly the technique. I think it has something to do with their gastric motility mainly, and the pylorus and the coordination, rather than the fundus, the fundoplication itself. Now, there are some unique patients, like the vomiting child. This is a patient who comes to your clinic with vomiting, but he is good. He has no issues. He doesn't have any weight loss. He doesn't have any respiratory symptoms. But the family are complaining, and they go to the medical team and they give them some Zantac or some omeprazole. Oh, he's still vomiting. You really have to look for something else. Probably he has gastroparesis. Whether he's small or, young or old, you really have to talk about the technique of feeding, because some of them, they cannot tolerate large meals or large feeds. Malrotation sometimes create this problem. So you may have to, with the contrast study that will show you, uncomplicated GERD, that's what it is. Regurgitation as opposed to true vomiting. This is another issue. You really, from history, you want to know, does he really feed completely, then he vomits after some time, or while he's feeding, he vomits? This is a difference. He's choking, maybe he's regurgitating. You could due to a problem with swallowing rather than vomiting. The CNS bedridden patients, these are very, very controversial sometimes. In some institutions, they don't do fundus because they say the rate of recurrence. So they end up putting just a GT or a GJ or a J to start with, or a GT and J. And this is very, peculiar patients. You really have to decide what is the goal of the management. Okay, if you have a complete bedridden patient, okay, and he's not vomiting, he may be fit for a GJ or a J only. Okay, that's an extreme. We all remember what Bianchi has done in UK. He developed this gastro-esophageal dissociation. I think it's very aggressive, where he cuts the stomach of the esophagus and put a limb to drain the esophagus in order to prevent the respiratory complication. I think if you put a GT to drain it and a J, I think you will be able to attain that goal without this aggressive surgical approach. The unique patients, again, the esophageal atresia, as I mentioned, 40 to 70%, they will have the disease. They may have vomiting, dysphagia, recurrent anastomotic stricture, respiratory symptoms. As I said before, the literature is full of data. Some of them, up to 75%, will need surgical treatment. Again, now you'll ask yourself, the esophagus here is not really moving well. So are you going to put a 360 or you will put a partial one? If you do the 360, which is really loose, not tight, you should be okay. The recurrence rate is 30%. Again, my personal experience, we don't do this much. And also when we do it, we don't really redo 30% of those. So now this is just a peculiar type of patients, the congenital heart disease patients. At King Faisal, we do more than 500, 600 procedures a year. And we do have consults from them regularly about babies who are really tiny in size. They cannot feed them because of swallowing problems or reflux, and they cannot gain weight in order to be able to do the corrective cardiac procedure for them. So they refer them to us, and we end up saving their lives, as I have. I'm going to show you the data now. So reflux is a physiological phenomenon in infants. It becomes pathological when there are complications. It has been identified with increasing frequency over the last 2 decades because now we pay attention to them. And surgery for GERD calendar is one of the common major operations performed in infants and children in general. Now, in uncorrected states, the cardiac patient with these lesions are likely to have increased metabolic demands and pulmonary overcirculation, putting them at risk of both failure to thrive and pulmonary complications. There is a good number of them will have also swallowing incoordination. Correction of the cardiac anomalies have been shown to expedite growth and development. That's very important, and we attest to it by this data that I'm showing you now. So there is scarcity of knowledge regarding the outcome of GERD surgical treatment in pediatric patients with congenital cardiac disease. This one here, it says feeding gastrostomy in children with complex heart. They concluded that they tolerate an open stem gastrostomy well with minimal major complications, and these support very selective use of fundu rather than funduing everybody. The issue of this study, they did not address the swallowing incoordination that has no comparative arm. Another study here in 2013 talked about the reflux surgery, the laparoscopic ones, for a certain type with the single ventricle physiology. They documented the safety of it and its usage. Again, another study here, they found that clinical symptoms of persistent emesis or respiratory wheezing after feeding disappear with duodenal tube feeding. This is again, just you put an ND, and they concluded that these tubes will improve the weight gain and improve their pulmonary hypertension. Problem here, when you put a tube like this, how many times you need to replace it, extended care, the nature of the patients themselves, and there is still an aspiration risk, and small number of patients will have problems with it. Another study here, talking about the fundoplication and its effectiveness in those ones, they concluded that the weight gain in this high-risk population can be expected. They did 112 patients, 104 procedures. They documented the safety and feasibility, and mortality rate was high because of the disease rather than the operations itself. Another study in 1999 talked about after repair of the AV septal defects, comparison medical versus surgical, and they concluded that in this specific type, Down syndrome with the congenital heart, who underwent fundu are less likely to experience major complications of reflux early after the cardiac surgery than those treated with medical treatment. Here another study talked about the impact of early fundu or gastrostomy on the midterm outcomes for these patients with single ventricle. And they said the need for early fundu is associated with decreased transplant-free survival for patients with palliated single ventricle. So the aim of this study that we did is to review our experience at King Faisal with this specific type of patients who underwent the fundoplication for severe GERD or swallowing incoordination. It's a one-center experience, retrospective review, and from 2001 and 2015. And I'm updating this data regularly, by the way. The results, during that time, 150 patients with congenital cardiac disease ended up with fundus. only 4 procedures were performed during the first 4 years of the review, because at that time, the belief was these patients are sick. You don't want to take them to the OR, just put an NG, put them on NJ even and wait. After that, we started becoming liberal with them because we found some patients who are having swallowing incoordination. Whatever you do, it won't help them. We usually assist about 500 to 600 a year. So 85 of those were males, 65 were females, mean age 20 months, 2 to 48. All patients went for correction before Nissim Fundu. Correction for the first stage, most of them. And this is just the heart issues that they have. And their symptoms mainly were respiratory in 78, failure to thrive in half of them, and swallowing in 22%. This is very important. The pre-operative weight was 4.8, anywhere from 1.8 to 14 kg. All investigated with barium swallow, showed moderate to severe. All had laparoscopic approach except one, and all had gastrostomy tube insertion during the procedure. The mean follow-up was 26 months. All had resolution of their symptoms except 4. 3 died secondary to cardiac disease. Mean weight post-surgery was 7.2. If you remember, it was 4.5. And this is within 3 to 6 months, okay? So the mean weight as I said, 4.8. So this is very significant. And most of these patients, when we see them in the clinic immediately, 2 to 3 months, we see the difference. So we concluded that the laparoscopic approach is effective, option, and safe for these patients. And it may suggest a change in attitude towards the management of GERD in this type of patients. Again, the medically uncontrolled, this is another unique patient. If you have a child managed medically and he's stable now, and they ask you as a surgeon, what shall we do now? If we stop the LOSIC, he comes back with the symptoms. What to do? I don't think there is an evidence for that. The evidence now suggests that the medications are safe, but nobody knows for how long will continue. The other thing is the cost and side effects, whether to do a Fundu now and let them go without any medications or to continue these medications. No, nobody knows. But if there is an anatomical abnormality like hiatal hernia or obstruction or something, surgical approach will be the way to go. Now, recurrence and redos, I think if it's done well first time, no redos should be considered. You really have to understand the patient. You have to make sure that the redo will do it. I was asked one day to check a patient who had 3-time redos, okay, by a colleague. And when I saw the patient, I told them, if I go back and tighten it again, he will have the same 2-3 months until come back. And we ended up putting a jejunostomy tube on that patient with the gastrostomy that she had. And since then, she's been doing well. Thank you so much. Hopefully that didn't take longer than usual. And it's now open for questions, unless Raif has another plan.
Thank you, Prof. Saud, for your thorough review presentation. We indeed have multiple questions from our audience I would like to share with you. The first question is, if the patient came with GERD and he has cerebral palsy, is the neurological impairment an absolute indication for fundoplication, or there is a need to try medical management first?
Well, CP patients, as you all know, are different. If you have a CP who is really functional, not functional in the sense that he functions, but he's in good shape. Some of them are able even to take oral, and they don't have swallowing, incoordination, and no respiratory symptoms, I will say try medical. But most of these patients, when you get them, sometimes we get them even too late. They already started having respiratory symptoms, and they have swallowing incoordination. And in my opinion, I think a Fundu and a gastrostomy tube is the way to go, and only allow them to take orally what is safe by assessment of our colleagues from speech therapy.
The other question, Prof, what are the indications for ROX in Y? Esophagogynostomy for gastro-esophageal reflux.
Are you talking about the raw limb that goes to the esophagus, or?
Yeah, it's basically the esophagogastric dissociation.
Yeah. To be honest with you, I don't see clear indication for it. Bianchi, when he did it, I think he was facing those difficult patients who are having repeated chest infections. My bias, if they reach that stage, they may benefit from a J tube directly in the jejunum, and the gastric tube always open for drainage. Now, in my opinion, that will work. And if someone says, even with that, they develop repeated chest infections, then I will say their problem is not in the stomach, their problem here. They are unable to manage their own secretions. If you manage it, some of them, they may need a tracheostomy in order to be able to suction them. But the dissociation, to be honest, I think it's very aggressive, and I'm not sure really that it adds much value to the assessment of the function here.
Question from Dr. Tariq. How you can avoid injury to the anterior vagus nerve when anchoring the stitch?
That's a good question, but usually the stitch itself, and in my opinion, I don't even go to the esophagus. Sometimes I take it just in the areolar tissue above it, or take it to the on the crurus. Now, let us ask ourselves questions now. If you take the nerve with you, what's going to happen? Gastric motility issue? Maybe, but you still have the other one intact from the other side. I just have to say that I never had a problem with it. That's not a good answer, that I didn't have a problem. But I don't see that you can avoid it, because as I said now, I don't really dissect. And even if you dissect, it's actually stuck to the esophageal wall. And people even may argue, dissecting there, you may injure the nerve. But I think if you just take the areolar tissue, okay, I think you are safe, because it's really stuck on the esophagus itself.
Dr. Hani asked, Prof, what type of suture material do you use for fundoplication, absorbable or not?
And I always do 2O silk. It's good. It's long acting. Some people, they use the Ethibond, but Ethibond, I hate it with the tying. It's not really as resilient as the silk.
Another question, Prof, what do you consider is the optimal drop length in infants?
To be honest, you see, we know from adult studies that they say 2 centimeters. In pediatric, I think if you can get 1 or 1.5, you're fine. But I won't measure it. Just put 1 centimeter to 1.5 is all what you need.
Another question, if we have a newborn with muscular atrophy and he is ventilator dependent with severe GERD, if gastrostomy feed is needed and he's scheduled for tracheostomy, would you go for only gastrostomy in the same sitting?
Would you please repeat the questions? I'm sorry, I didn't hear part of it.
So basically, it's a case of muscular atrophy with a patient or a newborn with muscular atrophy and ventilator dependent, and he has severe GERD. The question is, if the patient needs tracheostomy and gastrostomy, would you do it in the same sitting?
Yeah, that's actually perfect sense. You go, they intubate the baby, you do your fundo and gastrostomy, and at the end, the ENT surgeon will come and do the trach, and you're out.
Yeah. Doctor, do you think that patients with development delay need fundoplication after the GT session?
The gastric delay, you said?
No, the developmental delay.
Developmental delay. And the question, do they need gastrostomy or do they need fundo?
Do they need fundoplication after the gastrostomy too?
I think so, because those patients are prone to swallowing incoordination and, aspiration. And when you put the gastrostomy in place, you are increasing the chances of GERD. And that really will give them more to go the other direction and challenge them here. And I think it makes perfect sense that you combine it with fundo. In actual fact, some of the patients, when they come to my clinic, the parents say, don't do anything, just put a tube. And I refuse to do the surgery because I've had cases in the past that we used to do PEG only, like a percutaneous endoscopic tube for them. And they end up with aspiration pneumonias, and that's not good for them. And the fundoplication is a benign procedure because it does not really affect their abilities to feed in the future. So you really have to talk to your patients or their parents openly, and you explain to them what entails in the surgery. Some of them, when you say we want to wrap and we want to tie, we want to things, they think that you are really cutting the esophagus and preventing any future feeds. Although they may know in the back of their mind that this child will never eat orally, but they want to keep that, hope. So you have to spit it out to say, listen, when we do this, this protects them from that, and it will not affect their ability to feed in the future.
Prof, is there any need for bioplasty or jejunostomy?
This has been debated between authorities and between the literature, but my take on this, if we are doing it because of a belief that the stomach is not moving well, data has shown if you do those, whether it is gastrojejunostomy or a pyloroplasty, it doesn't really help much. Why? Because you lost the propelling force on the stomach, if you really think of it. So it's not just this thing that it is holding, the stomach itself is not, pushing. So you're not really going to help it much. So I'm against it, to be honest. unless you have a pyloric stenosis like muscle thickening there, and this is mechanically obstructing, then okay. Otherwise, I won't do the routine one.
Prof, is there any intra-abdominal esophageal length needed to do the fundoplication, or is it differ according to the age?
As I said to you, since I started doing the many dissections, I didn't have to do a dissection of the esophagus. And in actual fact, I'm able to see that the esophagus is coming with me. In cases of esophageal atresia, okay, or a case that I go there and find a hiatal hernia, these are the ones that I may even scrutinize in order to get enough esophagus in order to repair the hiatus and do the fundoplication and resume the intra-abdominal esophagus. But most of them, they don't. You just create the window on the, like dissect on the left, then dissect on the right, create the window, bring the fundus, of course, inspect the hiatus if you need to do anything before the wrap, and just put it together and they will be fine.
Prof, also, we had a question. When do you consider the patient failed medical treatment?
I mentioned this during the presentation. You know, you really have to have a debate with your colleagues. If the patient is still having their complications, now they're not gaining weight, they still have respiratory symptoms, then this is failure. Whether it is because of compliance or it just didn't work, you need something done. Of course, you try with the patients. Like sometimes actually we get cases referred to us by our colleagues from pediatric gastroenterology saying they failed. And when you talk to the family, you know that they were not really communicated with well, or they are not compliant. So you really have to be frank with them to say, you are missing a chance to fix this child with, you know, medication, and now we are moving to an aggressive approach. At that point, you may get their attention and they will be more compliant. But it is a situation that you really have to rely on the indication. So your indication should not be just vomiting. It should be more than that. Failure to thrive, stricture, respiratory symptoms, etc.
Prof, we have more questions if you don't mind.
Go ahead. Okay. See that yellow part? That's the fundu or the fundus, the wrap. That's exactly the wrap. When the pressure on the stomach goes higher with feed, look at the one on the side, the wheel-like. The esophagus is the red one in the middle. And this is what happens in that part of the fundus. And this is the way the fundu works. So it is not because you put a tight stitch. You just have to put the right amount of fundus in order to be able to have an efficient wrap. This is very, very important concept, okay? You may not read it in a book, but that's where you have to concentrate when you do the procedure. Because if you do the procedure with a floppy, you know, fundus, or with a lot of stomach wall coming in, you will never be able to attain what I just showed you here on the paper. You really have to have the right amount of the fundus. Sometimes I put the stitch. The first one is difficult because you're holding, but when I put it, I evaluate the amount of fundus in the area. If it is floppy, then I start making more stitches above, and I cut the one and below till I'm satisfied that I have a good amount that's not really pressing on the esophagus, but it's snug. So I will have this effect that I just showed you here, which is having this part snug, and it has the effect of this power there.
Okay,
next question.
Is asking if we can repeat this point again with the drop.
Here. See, this part is the wrap, okay? So the amount of fundus that you wrap is here. You want to see something like this. This is the way it works. When there is food here, the pressure will increase in the stomach. The same thing gonna happen here. I explained it earlier, like the use of the sphygmomanometer on your arm when you measure your blood pressure. So here, if you are really floppy and you have a lot of stomach and it is really, really floppy, you will not have a good occlusive effect like this one. And also, you don't want to make it very, very tight, because if you make it tight, you will have dysphagia here. Clear? This comes with experience. But as I said, when you put the first one, evaluate the amount of the fundus. Am I putting still a lot of fundus behind? Then put something shorter and cut the one below. You really make sure that you are having the right amount. People who worked with me, I showed it to them. So it is important that you ask the person that you worked with, saying, is it floppy? It's not floppy, how to assess it.
Prof, there is a question and I will extend it. The question is, how do you diagnose patient with post-operative herniated wrap? And I would ask, how would you follow up with this patient after fundoplication?
We'll start with the second one. Follow up for fundoplication patients is usual clinical. You just see them first in the clinic. I usually send them on Q2 hours feeds because you don't want them to put a lot of volume that will affect your wrap. You don't want it to be, undone, and you will lose the effect of the closure. And then when you see them in the clinic after 6 to 8 weeks, you start ask them to increase the volume because that will help the weight. One more trick here. Developmental delay patients, you don't want them to gain a lot of weight. If they were really failure to thrive, skin on bone, you let them really gain some, so you will start seeing their faces and they get better. But you really have to put a clear mark on the weight that you want to reach, because the family now will start putting feed and they want to see this patient swell. Patient will not move. He will be a burden on his family for holding and putting and taking from one place to the other. So you really have to tell them, we want a steady, slow weight gain. Make them anabolic, but you don't want them to gain weight quickly. And you start introducing even other types of feeds. Like ask them to cook anything in boiled water. Then after that, they put it with the milk, and they really make it really thin as a juice. So it will be like a milkshake. And this will be different meal from the milk that they're taking. So they can do it 3 times, 4 times a day and complement it with milk for the same amount that you allow them to do every 3 to 4 hours. Another common issue is pay attention to your colleagues from nutrition. The dietitians usually take them in the clinic and they say, oh, now we have a GT, let's just put feeds. And he is 10 years old, his weight should be 35. So we will aim for 35. The child is only 12 or 15, and he is developmentally delayed. He shouldn't be compared with other normal kids. Give him some gain in order to improve his, texture. So you see some fat. But after that, ask them to take a steady increase rather than a sudden one, and he shouldn't really attain the weight that's for normal people. For the wrap, when it goes into the chest, hiatal hernia, this is what you meant, Raif, postoperatively?
Yes, Prof.
Yeah. This is, in my opinion, one of two. Either there was a hiatal hernia that was missed at the beginning, so please pay attention. When you are dissecting in the retroesophageal, before you bring the fundus from the left to the right, watch the crura. If they are really spaced, then you have to fix it. If it happens later, means that the child, especially with the CP patients or hypotonic patients, it opens, then you may have to go there, bring the wrap down and fix the hiatus, and they should do well, inshallah.
Prof, another question is if the child has CB and he has swallowing discoordination and increased oral secretion, will the fundoplication worsen the saliva clearance? And shall we avoid fundoplication if there is no reflux in the upper GI?
I already mentioned to you what's my position in these patients. The developmental delay, I think they do have reflux by definition. Even if you don't see it on a contrast or on a milk scan for an hour and a half, if they have one episode and the milk that you put in the GT goes in there, they will have a massive aspiration and they may die. The amount of saliva, whether it will increase with fundo or not, if you are talking about someone who's like a tight trap and that created an obstruction, this is wrong technique. The technique should allow the esophageal secretions and even oral intake to go down without any problem. You just have to study the patient. If you are thinking that there is pooling in the esophagus, then it goes up, then you have to do a contrast study to see if there is any obstruction at that area or not. If there is, then you need to dilate it. If there isn't, then this is a swallowing incoordination. Whether it's increased because of feeds, the malvagal effect, they start adding secretions, you have to ask our colleagues from ENT. So they have some medications to give, anticholinergics, I think, they dry them, okay? Some of them even they remove their some of their salivary glands, and the ultimate ones, the extreme, they do a trach for them. And we've done it in few cases because these are very, very difficult to control. They cannot deal with their own secretions. Most of them, they will deal with their own secretions. Unless you challenge them with anything oral, then they will be having the swallowing coordination complications.
Prof, the last question is how do you approach laparoscopy those patients with severe scoliosis?
Well, there are two challenging areas here. One is how to put them on the table, okay? And in those cases, because of the muscle contractions, you won't know. Every patient has its own position, okay? Sometimes the legs are on one side and you can just put them like this and suddenly you have access. Some of them, you push it on the side and you will have an access. Sometimes we don't do the positioning that I told you. You may have to innovate in the position of the trocars. You may have to do it on the side rather than doing it in the same, direction that I told you, from below toward the hiatus. So you really have to be innovative in those patients. But most of the time, they're not bad. The older ones, you can put, the straps and you put the legs and you just open them, you push them. The other thing, it depends also on how long do you need to stay doing the procedure. Since I'm doing it in 30, 40 minutes, sometimes I compromise the position a little bit because I know I will be finished in 30 minutes. But if you are still doing it and you anticipate you will have difficulties or you will do other procedures with it, you may not be able to put them in a certain positions. You really have to do something. Now, will you face one case that you will never be able to put a laparoscope, like let's just say someone who has flexion at the hips and the legs are coming like that, and there is no way, you open it right, left, and you can't do it? Maybe. And those are the ones that you may have to do open.
Very clear. With this question, we wrap up our question, Prof. Any last message for our audience, Prof?
I think the first message that I mentioned to you, that this is an interesting disease, especially if you are dealing with these interesting patients. The developmental delay patients are the most difficult to deal with those, but I think with good understanding of the nature of the patient, the goal of the treatment is very important. You don't want to be doing something that your goal is different. And also communication with your colleagues from the other teams and with the family, and what I just told you in the presentation regarding how to investigate them, how to do it, and finally the technique, which will come with time. Thank you so much for this opportunity. I wish you all the best, and please do communicate with me in anything you want, especially that most of you are trainees, and that's why I'm here, by the way.
On behalf of the organizing committee and the audience, I would like to thank you, Prof. Saud, for the presentation and the discussion. Your time and efforts are well appreciated. Thank you.
يعطيكم العافية شباب. في أمان الله.